Hey everyone, welcome to this focused explainer of the RCOG Green-top Guideline number 13. I'm absolutely thrilled to guide you through this material today. We're going to break down the exact clinical pathways for managing chickenpox in pregnancy. Now, I know chickenpox might just seem like a run-of-the-mill childhood illness, but when it happens during pregnancy, it can escalate incredibly fast into a life-threatening situation for both the mother and the fetus. So we're going to extract the absolute highest yield points from the source guidelines so you can tackle these exam scenarios with total confidence. All right, let's dive right in. To make sure you hit every single key exam domain and truly grasp the complete clinical picture, we're going to follow the chronological pathway right from exposure all the way to delivery. We'll be looking at screening and prophylaxis, active maternal infection, severe disease and admission, fetal varicella syndrome, and finally, delivery and neonatal care. All right, part 1, screening and prophylaxis. Let's talk about managing that initial exposure.
So let's start with a patient who's just been exposed to chickenpox. How do we screen them, and exactly when do we intervene? You really need to notice this critical exam distinction in IgG thresholds for offering post-exposure prophylaxis, or PEP. For your standard immunocompetent pregnant patient who has had a significant exposure and unknown immunity, you offer PEP if their VZIG IgG is negative, or if it's less than 100 milli-international units per milliliter. But if that patient is immunocompromised, let's say they're on systemic corticosteroids, that threshold actually jumps up to less than 150. Definitely don't let that little nuance slip past you.
And this perfectly lays out the timelines you absolutely must memorize. If a non-immune patient is exposed, the first-line PEP is oral Aciclovir, and it's given specifically from day 7 to day 14 post-exposure. Now, you might be wondering, why delay until day 7? Well, studies actually show it's less effective at preventing clinical infection if you start it right away. Plus, you've got to counsel the woman on her potentially infectious window. If she doesn't get Varicella-zoster immunoglobulin, or VZIG, she's infectious from day 8 to 21. But if she does get VZIG, that window extends all the way out to day 28. So, to be super clear, oral Aciclovir is your #1 choice for PEP. VZIG is no longer the default option. It's strictly reserved for patients who have contraindications to antivirals or if they experience intolerable adverse effects from them. Keep in mind this was a recent and pretty major update in the guidelines.
Moving right along to part 2, active maternal infection. It's time for timely interventions and Aciclovir.
Now, imagine a patient comes in, and it's not just an exposure anymore. She has an active rash. What are our immediate clinical steps? Well, before we treat, we have to understand the stakes. You've got to outline these severe maternal morbidity risks in your exams. Adults with varicella face significantly higher risks of massive complications like hepatitis, encephalitis, and, even death. But the real standout risk you need to look out for is pneumonia, which complicates up to 10 to 14% of cases in some series. And crucially, the risk of severe respiratory compromise gets much worse later in pregnancy, basically because the physical weight of the gravid uterus is pushing up on the diaphragm.
Okay, so how do we actually handle this? First things first, isolation is absolutely key. Keep her far away from other susceptible pregnant women and neonates. Then we look at the really strict criteria for using oral Aciclovir. You prescribe it if she's at 20 weeks gestation or beyond, and she presents within 24 hours of the rash onset. If she's under 20 weeks, the guidelines say you should, quote-unquote, consider it, but over 20 weeks, it is a firm recommendation to prescribe. And finally, advise her on basic hygiene to prevent secondary bacterial skin infections, because those are a super common complication.
The exact steps for managing an immunocompetent patient presenting with clinical chickenpox are totally clear-cut here. But please note this massive distinction. VZIG has absolutely zero therapeutic benefit once the rash is actually developed. I'll say it again. Do not prescribe VZIG for an active infection.
Let's move to part 3, severe disease and admission. This is where the MDT approach comes in. So what physical signs tell us we need an immediate escalation of care and hospital admission? The absolutely crucial point here is knowing your red flags. These are the physical signs that mean you must refer the patient immediately to a hospital equipped with intensive care facilities. If a patient complains of a cough or any kind of respiratory deterioration, you act right away. Neurological signs like photophobia, drowsiness, or seizures, those point straight to encephalitis. And dermatologically, keep a close eye out for a bleeding, hemorrhagic rash or a really dense rash that involves the mucosal membranes. These are literal life-threatening emergencies. And hey, never ever forget to explicitly mention multidisciplinary team or MDT involvement for these high-risk patients. It is a massive scoring point in your clinical exams, and more importantly, it's vital for keeping the patient safe. You need a virologist, an obstetrician, and a neonatologist all bringing their expertise to the table.
When a patient meets the criteria for severe infection, the algorithm is super clear. You mandate an immediate shift from oral straight to intravenous Aciclovir. Oral medication simply is not going to cut it when the disease becomes systemic and severe. Okay, part 4, fetal varicella syndrome. Let's dig into the risks and how to counsel your patients.
Shifting our focus from the mother to the fetus, how do we correctly counsel women on these risks? Well, here is a classic exam question for you. What is the critical gestational timeline associated with fetal varicella syndrome, or FVS? The answer? It predominantly happens if maternal infection occurs at less than 28 weeks of gestation. You've got to deliver these high-yield counseling points super clearly. First off, the absolute risk is actually quite small, hovering right around 1%. And fascinatingly, FVS isn't even caused by the initial viral infection itself, but rather by a subsequent herpes-zoster reactivation happening right in utero. For monitoring, you refer to fetal medicine at 16 to 20 weeks, or you wait 5 weeks post-infection. Why the wait? Because ultrasound has a 5-week lag for detecting structural abnormalities, like limb hypoplasia or microcephaly. And if you're tossing around the idea of amniocentesis for VZV DNA, you have to warn the patient. It has a high negative predictive value, which means if it's negative, the baby is likely fine, but it has a very poor positive predictive value. A positive amnio definitely does not guarantee the baby will develop FVS.
So, to quickly wrap up that under 28-week infection pathway, inform the mother of the 1% risk, refer her for an ultrasound after that 5-week lag, and consider amniocentesis really carefully.
And finally, part 5, delivery and neonatal care, because timing really is everything here.
So if our patient is getting close to term, how do we safely manage delivery to minimize all these neonatal and maternal risks? I really want you to map out this critical late pregnancy window in your head. If infection happens in the last 4 weeks of pregnancy, up to 50% of babies get infected. But the absolute danger zone, the highest risk for severe neonatal chickenpox, is if the maternal rash pops up anywhere from 7 days before delivery to 7 days after delivery. Therefore, if a mother develops chickenpox near term, you follow the rule of 7s. You must try your hardest to delay a planned delivery for at least 7 days after her rash starts. This stops delivery from happening during her highly viremic period, and it gives her body that vital time to create and passively transfer protective antibodies right across the placenta to the baby. Now, if delivery is absolutely required, let's compare neuroaxial anesthesia precautions. There is a theoretical risk of transmitting the virus from skin lesions straight into the central nervous system if you use spinal anesthesia. Epidural might be safer because the dura isn't penetrated, though it does require a larger needle. But the absolute non-negotiable rule here for the anesthetist is they have to choose a needle insertion site completely free of cutaneous lesions. Once the baby is born, your job isn't quite done. You need to ensure you cover these immediate postpartum steps. The neonatologist has to be notified of all babies born to women who had chickenpox at any point during their pregnancy. If the maternal rash fell into that ultra-critical window of 7 days pre to 7 days post-delivery, the neonate must receive VZIG immediately. And finally, breastfeeding is perfectly safe and actually actively encouraged. The only catch is if there are active lesions right on the breast or close to the nipple, in which case the mom should just express her milk until they crust over. All right, we have covered a tremendous amount of ground today. Let's bring all these high-yield pathways together to really test your readiness and see how this builds into a real-world clinical application. I'm going to leave you with this classic clinical scenario to really cement those critical thresholds we've discussed in the explainer today. Imagine a 38-week pregnant patient presents to you with a dense hemorrhagic chickenpox rash and a cough. What are your immediate next steps? Think about those red flags. The hemorrhagic rash and cough are screaming signs of severe, life-threatening disease. Your next steps should instantly be, number 1, isolate the patient and arrange an immediate emergency hospital admission, likely straight to the ICU. Number 2, start intravenous, not oral, Aciclovir. And number 3, urgently convene your multidisciplinary team, grabbing your obstetrician, virologist, and neonatologist, while planning to delay delivery if it's safely possible so antibody transfer can happen. But what if this exact same patient presented in spontaneous preterm labor? How does the risk-benefit ratio of tocolysis weigh against a potentially catastrophic viremic delivery? The MDT guidelines provide a fantastic framework, but as clinicians, the final judgment call is ultimately yours. Keep questioning, keep studying, and I'll catch you in the next explainer.